We will discuss two topics today, atelectasis or collapse and acute respiratory distress syndrome. By the end of this lecture, you should be able to define lung atelectasis or collapse, identify its types and causes. Also, you must define acute respiratory distress syndrome and list its causes. Explain the pathogenesis of respiratory distress syndrome in adult and neonatal type. So we have two main types of acute respiratory distress syndrome according to the age, adult and neonatal type. Describe the morphology of acute respiratory distress syndrome. Identify the clinical sequences and comparison between the acute, adult and neonatal type. The definition of lung collapse is inadequate expansion of air spaces. We have two types, collapse of previously inflated lung due to other causes, we call it secondary, or failure of expansion of air spaces after birth. This is the primary type, we call it neonatal atelectasis. We will start by the types of secondary lung collapse. We have compression collapse, absorption collapse, and contraction collapse. For each one, you must know the causes of each type and the position of the mediastinum in each one. Compression collapse results from accumulation of air in case of pneumothorax, fluid, pleural effusion, or blood, hemothorax, in the pleural cavity, leading to pressure on the lung, causing its collapse. The site of the mediastinum in that type, the mediastinum shifted away from the affected or collapsed lung and go to the or pushed to the normal side. Here is the pleural cavity. The pleural cavity is filled by air, fluid, or blood, leading to compression on the of the lung. So we call it collapsed lung, and then more compression occur, shifting the or pushing the mediastinum towards the normal side. Very important to drain the fluid or air in the pleural cavity to prevent the organization and fibrosis of the outer surface of the lung. So re-expansion can occur. And also to avoid superadded infection that can occur in the collapsed lung. This is an example of compression collapse. Here we have the left side and the right side of the lung. The right side is normal, and the left side, here we have the air accumulated in the pleural cavity, compressing the left lung here and pushing the mediastinum to the right side. Here we have the shadow of the heart goes to the or shifted to the right side. So the mediastinum is shifted away from the affected lung and pushed to the normal side. This is an example of left pneumothorax and left lung collapse. Another example, we have here the left side. This is abnormal, and this is the right side, which is normal. We have here the bronchial tree, and the pleural cavity here is filled with fluid that push the left lung to the other side, and the mediastinum goes to the right side. The shadow here of air inside the trachea and the bronchi identifies the position of the mediastinum, which is shifted to the normal side. So this is example of left pleural effusion. The mediastinum here is shifted away from the collapsed left lung and pushed to the normal right lung. This is the mediastinum. So this is the example of compression collapse. The absorption collapse or resorption collapse occur in cases of bronchial obstruction. Bronchial obstruction can happen due to aspiration of foreign body in children, can occur due to obstruction by mucus or mucopurulent plaque in cases of chronic bronchitis, bronchopneumonia, bronchiectasis, or any severe lung infection. Can occur in aspiration of blood clots during surgery with loss of cough reflexes. Can occur also if tumor or mass occur in the main bronchus, leading to obstruction. So these causes of obstruction that can occur here in the main bronchus leading to absorption collapse or resorption collapse. The causes of resorption collapse, it occur when bronchial obstruction by mucus plug or foreign body prevents air from reaching the distal air spaces. For a time, collateral air ventilation may keep the obstructed segment open, and the position of the mediastinum is shifted toward the affected lung, the opposite of compression collapse. The mediastinum here is shifted toward the affected or diseased or collapsed lung. This is example of absorption collapse. The left side is normal, and the affected side or the collapsed side is the right side. Obstruction collapse here occur in the right side with shifting of the mediastinum towards the collapsed side. This slide to compare between the two types of collapse, compression and absorption collapse. This is an example of right pneumothorax of right lung with collapse of the right lung and shift of the mediastinum towards the normal left lung. And on the opposite here, the right side show right lung collapse here with a shift of the mediastinum towards the diseased collapsed side. Another example to compare between compression and absorption collapse. This is compression collapse of the right lung due to right pleural effusion with shifting of the mediastinum. Here is the shadow of the mediastinum towards the right left lung. And the other example is right absorption collapse with shifting of the mediastinum towards the collapsed lung away from the normal side. Last example of absorption collapse. This is the normal lung shadow, and this is the absorption collapse of the right lung with shifting of the mediastinum towards the collapsed right lung. So a compression collapse pushes the mediastinum toward the normal lung, and absorption collapse pulls the mediastinum towards the diseased obstructed lung. The third type of secondary collapse called contraction collapse. It occurs when either localized or generalized fibrotic changes occur in the lung or pleura, resulting from previous organization of infection. Leading to preventing lung expansion. The consequences of lung collapse. The lung collapse will result in shunting of deoxygenated blood from the pulmonary arteries to pulmonary veins, thus giving rise to ventilation perfusion imbalance and hypoxia occur. Atelectasis is potentially reversible except in contraction collapse and should be treated promptly to prevent hypoxemia or hypoxia and also prevent the infection of collapsed lung. The gross picture of the collapsed lung. The pleural surfaces are wrinkled due to loss of lung volume. The cut surface of the lung appears airless, rubbery, and bluish in color. The microscopic picture of the collapsed lung. The alveoli are collapsed. appearing as slit-like spaces. The pulmonary arterioles are constricted. In prolonged cases, showed a regeneration of pneumocytes type 2 and progressive pulmonary fibrosis with or without infection. Then we will move to the second topic today, which is the acute respiratory distress syndrome. The definition of this syndrome is respiratory failure or life-threatening respiratory insufficiency occurring within 1 week of clinical insult with cyanosis and severe hypoxia and bilateral opacities on chest X-ray. Acute respiratory distress syndrome is characterized by diffuse alveolar epithelial and endothelial cell damage, leading to acute lung edema with formation of hyaline membrane, resulting in respiratory insufficiency, ventilation perfusion imbalance, cyanosis, and severe hypoxia that may progress to multi-system failure. We will start by the adult type of acute respiratory distress syndrome. Causes of adult type, we have two main categories of the causes, direct injury and indirect injury. Direct injury including pulmonary infection, especially viral infection like coronavirus, aspiration of gastric content, inhalation of toxins, fat embolism, and near drowning. Indirect injury like sepsis, pancreatitis, severe trauma, and massive blood transfusion. The main site of injury in acute respiratory distress syndrome is focused on vascular endothelium and alveolar epithelium. The damage of endothelium results in increased capillary permeability, alveolar edema, and loss of diffusion capacity. The damage of type 2 pneumocytes results in decrease in the secretion of surfactant. What about the pathogenesis of acute respiratory distress syndrome? This diagram shows the normal alveolus lined by type 1 pneumocytes here and type 2 pneumocytes. And this is the lumen of the alveolus showing alveolar macrophages. And this is the alveolar capillary lined by endothelium. The alveolar capillary membrane is formed of two barriers, the microvascular endothelium and alveolar epithelium. In acute respiratory distress syndrome, there is damage of epithelial lining of the alveolus and the endothelial lining of the alveolar capillary. The pathogenesis of acute respiratory distress syndrome, starting from the alveolar macrophages, which secrete pro-inflammatory cytokines like interleukin 8 and 1. These cytokines leading to neutrophils chemotaxis. The neutrophils release proteolytic agents like proteases, oxidants, and leukotrienes. These proteolytic agents leading to alveolar epithelial and endothelial injury with increased vascular permeability and formation of hyaline membrane. This photo shows the pathogenesis of acute respiratory distress syndrome, starting from the alveolar macrophages, which secrete pro-inflammatory cytokines. These cytokines go to the blood, attract the neutrophils, which go inside the alveolus and secrete different proteolytic enzymes. These enzymes leading to damage of the lining epithelium of the alveolus with formation of alveolar hyaline membrane. The pathologic features of acute respiratory distress syndrome. The lungs are a dark red, firm, airless, and heavy. The microscopic picture showed necrosis of alveolar epithelial cells, intraalveolar and interstitial edema, congestion of alveolar capillaries, could be areas of hemorrhage, but the most characteristic finding is the formation of hyaline membrane, that consists of fibrin-rich edema fluid and remnants of necrotic epithelial cells. This photo shows a microscopic picture in case of acute respiratory distress syndrome. Some alveoli are collapsed, others are lined by the characteristic hyaline membrane here, and also this is the pink hyaline membrane. High power show the lining of the alveolus, which is the hyaline membrane, looks pink in color. In the organized stage of acute respiratory distress syndrome, there is a proliferation of type 2 pneumocytes, as here, and also proliferation of the interstitial fibroblasts leading to interstitial fibrosis. This is the example of X-ray in case of acute respiratory distress syndrome, showed bilateral diffuse lung opacities. The clinical features and consequences in acute respiratory distress syndrome. The acute stage can lead to severe respiratory distress and death. Supportive treatment can decrease mortality in about 40 to 60% of the cases. The predictors of poor prognosis are old age, bacteremia, and multisystem failure. The chronic condition can lead to diffuse interstitial fibrosis with chronic respiratory insufficiency. We finished the adult type of respiratory distress syndrome, and we will move to the neonatal type. The causes of neonatal respiratory distress syndrome, including prematurity due to decreased senses of surfactant. Cesarean section and infant of diabetic mothers could be causes, and we will discuss why. Other causes including excessive sedation to the mothers, aspiration of blood or amniotic fluid, intrauterine hypoxia due to compression from coiling of umbilical cord. The function of surfactant normally is to expand the alveoli of the lung. Due to deficiency of surfactant in like premature lung, the alveoli tend to collapse. Greater inspiratory effort is needed by the infant to open the alveoli. Then the infant rapidly tires from breathing. Atelectasis occur, then hypoxia, and epithelial and endothelial injury with formation of hyaline membrane. So in prematurity, reduced the surfactant senses, increase alveolar surface tension, and then collapse of the alveoli, leading to uneven perfusion and hypoventilation, hypoxia and hypercapnia, or increased carbon dioxide, with epithelial and endothelial cell damage and formation of hyaline membrane. In prematurity, there is decreased senses of surfactant. As we said, surfactant senses is regulated by hormones, mainly corticosteroids and insulin. Corticosteroids stimulate the formation of surfactant. During labor, due to stress, increase the surfactant release due to increase the corticosteroids. So in cesarean section, may be associated with increased risk of respiratory distress syndrome. Surfactant senses can be suppressed by compensatory high level of insulin in infant of diabetic mothers, because in diabetic mothers, the hyperglycemia causes hyperplasia of islet cells of pancreas in infant, leading to increase the level of insulin and decrease the formation of surfactant. This microscopic picture shows the alveoli lined by hyaline membrane, and this X-ray showed ground glass appearance a characteristic of neonatal respiratory distress syndrome. This is the ground glass appearance here. Looks like the glass. Summary of both types of acute respiratory distress syndrome, adult and neonatal types. The causes of adult type, including direct and indirect injury. The neonatal causes, prematurity, cesarean section, and diabetic mothers. Pathogenesis of adult respiratory distress syndrome, starting from activation of pulmonary macrophages, leading to release of pro-inflammatory mediators that attract neutrophils, which release proteases and mediators, causing damage of alveolar and endothelial cells, causing vascular leakage. In case of neonatal respiratory distress syndrome, absent or decreased surfactant lead to increased surface tension and collapse of the alveoli. Thank you.